Good afternoon. My lecture today is how to screen MSK system in no time. We believe that you people seeing the patients before us, so it's important for you to recognize which patient you have to refer to us, and they will take the proper treatment as soon as possible. So my objective today is how to assess MSK system, review important points in MSK history, MSK screening physical examination, and when to refer a patient to a rheumatologist. So we believe that musculoskeletal disorder are the most commonest cause of disability worldwide, and it's 20-25% of the GP's workload. So there are, as we all know, more than 200 different types of arthritis, both inflammatory and non-inflammatory. So it's not logic that you keep in your mind 200 different arthritis when you see the patient. So clinician has to have a classification scheme and learn how to place patient problem within the classification. There's 5 key questions which need to be answered when you see a patient with MSK problem. So does the problem arise from the joint, tendon, or muscle? Sometimes patient will come and say, I have shoulder problem, I have knee pain, but when you dig in the history, you'll find that the patient's problem is not in the joint itself, maybe from the soft tissue around the joint. Is the condition acute or chronic? And we have a cut of 6 weeks to define this acute or chronic problem. Is the condition inflammatory or non-inflammatory? So you have to ask more questions to know if this is inflammatory or non. I'll go into it later. What's the pattern of the affected area? What's the impact of the condition on the patient's life, which is the most important? If the condition is not affecting the patient's life, so most likely it's not significant. But if it's compromising his lifestyle, so most likely they have significant problem. So when you answer these 5 questions, you'll keep in your you'll have an idea in your mind what the patient is complaining of. This is just an example. So when you answer these questions, you'll say, okay, this patient has a chronic symmetrical inflammatory polyarthritis, mainly affecting the small joints of the hands and feet, which causing pain, difficulty with dressing and hygiene, and it's limiting his mobility. So in your mind, you will have a differential diagnosis for what your patient has. And this is the classification scheme. So you have arthritis, so is it inflammatory, is it non-inflammatory, is it part of the connective tissue disease that we know, and if it's inflammatory, is it acute, is it chronic, if not inflammatory, is it acute, chronic, and each of them has different differential diagnosis. So when you ask these questions, you will put in your mind what could be your patient has. Coming to MSK history, there are 4 important areas which need to be covered in MSK history. The current symptoms, the evolution of the problem, is it acute or chronic, the involvement of other systems, and the impact of the disease on the person's life. So regarding current symptoms, most of our patient comes with pain. So you have to ask more about pain. What is it? When does it start? Does it affect which area? Is it a referred pain? Is it a real pain? And then stiffness is important to differentiate whether this is inflammatory or non-inflammatory problem. And also joint swelling is really significant. If your patient has joint swelling, that means they have fusion, which is really signify arthritis more than arthralgia. And then the pattern of joint involvement, is it monoarticular when you have one joint involved? Is it posi or oligoarticular when you have less than 4 joints involved? Is it polyarticular if you have 4 and above? Or is it axial predominantly, which all of them, each of them has different differential diagnosis. You have to ask yourself, how does the symptoms evolve, and does it respond to a treatment at a certain point of time, and what kind of treatment they respond to. So if you have a patient telling you, I respond very well to non-steroidal anti-inflammatory drugs, this put you a hint, maybe this is a crystal arthropathy or non-inflammatory, because usually inflammatory disease doesn't get dramatic response with non-steroidal. If the symptoms, as I said before, last for more 6 weeks, this is generally described as chronic. In chronic disease, it might start insidiously, and they will have a different course with remission and relapses. And this is just an example of the chronology of condition. So patient with the upper graph, A, you have patient with crystal arthropathy, patient with acute gout. So this graph taken from the Western countries, so usually they have the acute flare near the Christmas Eve or like the New Year Eve, where they have a lot of alcohol intake. So usually they will have a acute flare, then they will be asymptomatically, and they will have another flare, and usually the flare lasts for a week. And the other graph is of patient with our inflammatory polyarthritis, RA, and usually you will have grumbling symptoms with flare, patient respond to steroid, then they will have, we'll start DMARD, then they will have like symptoms not very controlled, then you change the medication, patient go in remission. You have to ask about other system involvement because our inflammatory diseases affect different all the systems in the body. You have to ask about skin, eye, lung, brain, kidneys, and most of our patients, they will have what we call constitutional symptoms. They will have weight loss, fever, malaise, night sweats, and depression is also common in our patients. These are screening questions. If you don't have time, you just ask your patient these questions. And if the patient answers no for these questions, that's unlikely they will have a significant MSK problem. So you have to ask them, do you have any pain or stiffness in your muscle, joint, or back? Can you dress yourself completely without any difficulty? Can you walk up and down stairs without any difficulty? Coming to MSK exam, because you have to have an idea what your patient have, you have to examine them. So there is a system that's called GALS. It's a brief screening examination, takes 1 to 2 minutes. And it's really, it's highly sensitive in detecting any significant MSK problem. It stands for gait, arm, legs, and spine. So when the patient stands up in an anatomical position, you can just observe him from behind, from front, and on the sides, looking for the bulk and symmetry of the shoulder, gluteal, quadriceps, and calf muscles. You can check the limb alignment, alignment of the spine, equal level of iliac crest, equal ability to fully extend the elbow and knees, popliteal swelling, abnormalities in the feet, such as excessively high or low arch, profile, and clawing. And all of these can give you an idea if the patient have any MSK problem. For the arms, you can ask the patient to put their hand around their neck. You check for assess the shoulder abduction and external rotation and elbow flexion. And also, you have to ask the patient. It's working? So you ask the patient to show you their hands and check for any abnormalities, any swelling. And then they turn over their hands. Turn over their hand to check the muscles if there's any hypertrophy or any abnormalities. And at the same time, you can do the MCP's squeeze. It's a screening test to check any inflammation of the small joint of the hand. And really, we find this in our patient with inflammatory arthritis. For the legs, so you have to examine your patient lying position. You check the knee for flexion, extension, and at the same time, you check if there is any fusion. You check for crepitus as well. You do the patellar tap to check for fusion. And with the hip and knee flex in 90 degrees, you check the internal and external rotation of the hip as well. You can inspect the feet for swelling and deformity, and you do the same metatarsophalangeal joint squeeze test to check for joint tenderness at the small joint of the feet, which is also seen in our patient with inflammatory disorders. For the spine, you have to inspect the spine from behind for evidence of scoliosis, and you inspect from the sides for any evidence of abnormal lordosis or kyphosis. You ask the patient to tilt their head on the sides of their shoulder, bringing the ear toward the shoulder to assess lateral flexion of the neck, and ask your patient to bend to touch their toes to assess the function of the spine as well. And the crude way to check if there is the movement of the lumbar vertebra, you just put your fingers, and your fingers should come close together with the extension and separate with the flexion. If you have been altered to a musculoskeletal problem by the screening questions, your examination or spontaneous complaint of the patient, you need to take a detailed history, and you go to the specific joint that you think that's abnormal, and you make a detailed examination as well. So when you have to refer a patient to a rheumatologist, when you suspect inflammatory disease, please refer patient to us. Any patient with rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, or any patient with seronegative arthritis. When you suspect connective tissue disease, please refer the patient to us. In case of mechanical joint pain, we need you to refer these patients if they're not responding to optimal dosage of combined analgesic, and if there's any need for intra-articular injection with steroid, we're happy to see your patient. In summary, if you have patients who have no pain or stiffness and no difficulty in dressing themselves, are likely to be suffering from any significant MSK problem. GALS is a brief screening exam, as I said, which is highly sensitive in detecting significant abnormality in MSK. If you suspect inflammatory diseases, please refer patient to us. Thank you.